EM board bombs.
Welcome back to the EM Board Bombs episode. We're joined today by, of course, the two co-hosts, two co-founders, Dr. Briggs, Dr. Hussein. Dr. Hussein, thanks for joining us today. He's rocking it right now. If you're on YouTube, you can see his pale complexion, his bottles of acetaminophen and ibuprofen.
A few moments later.
Now, there are two switches on your defibrillator that allow you... Poor Iltifat, he's sick.
I should have brought those bottles with me.
By the way, we're
really
not sponsored. We're not sponsored by Tylenol.
We're not, but we love Tylenol so much.
It.
Hey, feel free. Actually, no, we don't do pharma, right? Yeah,
we don't do pharma.
Sorry,
yeah.
Tylenol.
Sorry, Bear. Sorry, Bear aspirin.
Nope.
Yeah. Anyway,
chugging through, man. I think my voice sounds okay, but I'll make it through. I've got my espresso off to the side here. So
tis the season. Tis the season of upper respiratory infections.
Nice glass, right?
Exactly.
Nice
I know. I like that. That's beautiful. Anyway, tis the season of upper respiratory infections. So Dr. Hussein is a trooper. We were talking about this yesterday over the phone because we do talk often outside the podcast.
We do. We enjoy each other's company.
It's not just the chemistry on the air; it's the chemistry off the air.
Yeah, that's what people don't understand. Like they think it's just like on air stuff. It's like no, we like to just have conversations about random things. While I was making chai yesterday, we were just having a great conversation.
Exactly. Hey, anyway. Speaking of great conversations, this is EM Board Bombs, emergency medicine board bombs, to be clear.
Yes,
and we are the podcast that tells you what you need to know for boards, for hashtag EM Life. And we don't waste any time. I know this seems like a waste of time to you, but this is kind of like, hashtag shift life. You show up, you shoot, shoot the ball a little bit with your staff, and then you get to work.
What you were about to say. You were about to say something else, but then you call yourself. That's great. Yeah, we're PG.
No, I didn't. I was not going to do that.
Keep going. Yes, I know. You don't curse at all.
We got to thank our one sponsor, the only sponsor we allow, Emergency Medicine News. Big shout out to them. You're used to hearing about them if you're a fan of the podcast. They are an excellent resource, thought-provoking articles, and it's all free if you're an emergency doctor.
It's awesome.
It's pretty awesome.
Yeah,
go to the website. You can do digital. If you like paper, you can do that too.
Yep.
Nothing wrong with reading a paper newspaper. That's like
not at all.
Vogue all of a sudden now. People don't like doing that, but yeah. Anyway, we won't get into that.
I like that too. I just I get on a plane and I just push out the thing, with the the paper. It's just there's nothing more just.
Yeah,
I don't know.
More satisfying.
Satisfying it.
Hey, let's dive into this. I'm going to do most of the talking here, as Dr. Hussein.
My husky voice.
Yeah. Don't worry, Dr. Hussein. You got that prescription I wrote for you for Augmentin and Decadron.
Oh, that's right.
And albuterol, right?
Yeah. And the Z-Throw. How are you going to forget the Z-Pack? The famous Z-Pack.
Just in case. You got all those, right?
Everything came through.
Yeah. And codeine drops as well.
Yes, exactly.
Tessalon pearls.
Yes, all of that.
Just everything. Throw everything at it. And none of it will work.
None of it.
Hey, we got a 72-year-old male. Oh my gosh, this is part 2. Welcome back to part 2.
Part 2.
We hope you enjoyed part 1 of Bradycardia. And if not, check it out. If you want to really be entertained, check out the YouTube channel episode of the Bradycardia part 1. Don't. Alexandra did the most epic video editing ever. So check that out if you want a really good laugh. There are some amazing social media edits to that, as well as graphics. It is pretty epic. So check it out if you're interested. Anyway, we got to talk about Bradycardia Part 2. We got a 72-year-old male with a history of coronary artery disease and previous MI. He's brought to the emergency department after experiencing episodes of dizziness, and he had a near syncopal episode prior to arrival. Almost fainted. His symptoms all started after he found out Nick Saban was retiring as Alabama's head coach. This is my first time reading this.
Hey, I loved I loved writing this one.
Yeah. As he's telling you his symptoms, he says "Roll Tide" at the end of each statement, stating his goal is that if he's about to die, to have "Roll Tide" be the last phrase he ever utters on this earth. His medications include aspirin, metoprolol, or some people call it metoprolol, and atorvastatin. On exam, he is alert, but appears pale and diaphoretic. His blood pressure
not crimson red.
No, I knew you were going to say that. His blood pressure is 95 over 60. Heart rate is 35 beats per minute, and respiratory rate is 16 breaths per minute. And that's an actual respiratory measurement, not the standard
not
16
the default,
that's always in the community. Yeah, exactly. An EKG reveals a wide QRS complex with a regular rhythm. So which of the following is the most appropriate initial management for this patient? Choice A, administer atropine. Choice B, immediate transcutaneous pacing. Choice C, IV fluid bolus. Choice D, Observe and reassess in 30 minutes.
Hey, quick summary here. This guy's pale. He's diaphoretic. His blood pressure is low. His heart rate's 35. Respiratory rate 16. And then the EKG shows wide complex, right? So wide QRX complex with a regular rhythm.
Right.
And then you're giving me these 4 choices.
You got it.
So atropine, immediate, transcutaneous pacing, IV fluid bolus, and then observe and reassess. In 30 minutes.
Just let it ride.
Be honest. It's not let it ride will never be the answer on EM board bombs. It's not how we roll.
We don't roll that off.
So the correct answer here is what, Dr. Briggs?
Correct answer here is choice B, transcutaneous pacing.
There we go. And that was the key. Yeah. I wanted to reemphasize that because I didn't want people to get lost in that EKG. Reveals a wide QRX complex with a regular rhythm because we're going to get into, I think a lot of people would have actually put atropine as the answer choice. But after you go through some of this explanation, and we did some of the, very brief pathophys last episode that got into this as well. Again, we don't really like pathophys, but it is important from a treatment standpoint for this. But hey, Briggs, just take
before we get into that, we got to talk about EM rapid bombs. Guess what's coming up in less than like 5 weeks?
Oh my gosh.
It's also a leap year.
If you look at our metrics, it's always hilarious to just see the traffic on EM rapid bombs and just seeing like how everyone just starts like binge using it. It's like, you get people like listening a couple episodes a week.
Right.
And then all of a sudden I'm like,
people
how are they listening to like 30 episodes in like 2 days?
Just prepping.
They're just, again, I have that mental image of someone with like a Monster Energy drink, like a Celsius.
Let's go.
And like a Red. Yeah, just let's go. Just sitting there.
Hey, so we're talking about EM Rapid Bombs, though. EM Rapid Bombs is our premium podcast, and it's pretty awesome. So it's an annual subscription basis. You sign up, you go to our website, emboardbombs.com, and it's like a 2-click process. You can pay with Apple Pay, too. You sign up, you get a private RSS feed, private link to our podcast. That's a separate premium podcast, and it downloads to your app of choice. It's flawless. It is no required separate login, anything like that. No. It's really nice. And so what you do is you get our premium episodes. We have 410 episodes as of this morning. I just launched a new one. And you get 4-minute episodes that go over, 4 to 6-minute episodes that go over multiple choice question. We tell you the wrong answers, right answers, and a coaching aspect, telling you how the test is going to ask that. We also separate what's real life and what's not. So we do tell you some educational pearls of, hey, if this was in real life, you would probably do this differently. And that's cool. So you get to know a variety of different things for EM Life and boards, but check it out.
Yeah, and I love it because, again, it's great for the interns, and then it's awesome for seasoned vets as well. When I did a recent road trip to Atlanta to visit my bro, I was just listening to it, and it was great to just kind of go through, refresh my own knowledge because we've done so many episodes now.
I know,
so
it's hard to
pretty
get
awesome.
Yeah.
And then even I got an email from a program director just the other day, and they were just really excited about it because they were just saying how it provides a great foundation as well for some of their interns, but then it's also awesome for their 30-year residents as well.
For sure.
Hey, let's get into it.
So,
hey, we've been repeating each other and overlapping a lot recently.
We have.
I feel like the sync is like,
it's strong. It's a strong sync right now.
The force is strong.
The force is strong. We got to back off a little bit though, so the listeners don't get confused. And I'll tone it down. I'll adjust the knobs.
Please.
Some knobology. So in this clinical scenario, we got a patient that's presenting with very symptomatic bradycardia, all the right signs of something really bad happening.
Yeah.
And it's characterized by this patient having a heart rate of 35. They're dizzy and near syncopal, which is classic for unstable bradycardia. And of course, they're hypotension. We really threw it at you to make sure you understood this patient is essentially about to die in the next 10 minutes if you don't do something, probably less than that.
Yeah.
And they have also a wide QRS complex and EKG. And we said in the last podcast in part 1, cue the music, Alexandra, part 1. In part 1, we mentioned a wide QRS complex was really bad. And meds don't really work on symptomatic wide complex bradycardia. All these findings indicate the patient's going to die in a few minutes. And so
with that caveat, though, what we talked about the first time, calcium might actually work, right? Because what could it be? Right? It could be hyperkalemia, right? So that's something to always kind of have in your back pocket as well, right? So anyways, continue.
Absolutely. All right, so wide QRS complex, the presence of a wide QRS complex, again, suggests the bradycardia is originating from that His-Purkinje system, the ventricles. And in that case, meds like atropine are just not going to work. They're not going to be as effective as they would be for the SA or AV node. let's be honest though, atropine kind of sucks in general. So we'll get to that in a minute though. So in the correct answer here, I'm just gonna throw shade on atropine. I always roll my eyes when someone says, "Let's give atropine." I'm like, "Sure, give atropine." Like, just waste 5 minutes of your. Anyway, so immediate transcutaneous pacing is the answer here, given the fact that the patient is unstable. You know, you've been in the exact scenarios I have. You just roll your eyes. Anyway,
It's great. Anyways, we'll get into it.
you're my usual Briggs tirade right now. Anyway, given the patient's instability, which is hypotension and the decreased perfusion, like the near syncopal episode, and the fact that meds are probably not going to work here because this is wide complex QRS bradycardia, start pacing immediately.
Please.
The thing is that this isn't that common of a procedure. On the list of common things emergency doctors fear about doing on shift, like vaginal delivery or compartment pressure checks, I don't know. This is probably up there too, I would say. Like transvenous pace replacement, and then maybe transcutaneous pacing, because you look at the Zoll and you're like, I know how to press the shock button, but I don't really do too much pacing.
And all that stuff.
Yeah, exactly. I don't know what the knobs to turn, everything. We'll help you out with this on this podcast. But this is the most appropriate thing to do, and you shouldn't back off just by saying, I'm not really feeling too good. Why don't we try something else instead? So I don't have to do that. It's not the right answer. So the other options that are incorrect, obviously atropine we already mentioned is wrong, because atropine, yes, that's the first line treatment for certain types of bradycardia. It doesn't work at all for cases that are wide QRS complex bradycardia.
Yep.
Now, what about IV fluid bolus choice C? That is part of the management. Sure, hang a bag of fluids, but that's not going to save this patient's life within a few minutes. Not the answer. Start it. It's not going to do anything really. And then choice D, observation and reassessment in 30 minutes while you go get your attending.
Sorry, this isn't the surgical ICU. Okay.
This is not the surgical ICU. We don't let this ride. This is inappropriate for a patient that's about to die. So we hope no one picked that answer. So why don't we dive into further? Last episode, again, we talked about the scary bradycardia cases and causes of bradycardia. Now let's talk about the management of symptomatic bradycardia. So Iltafat, why don't you break it out here, and then we'll dive into the meds and dive into electricity and then wrap it up.
Yeah. So obviously, look, patient's crashing. You're going to be doing multiple things at once. You might be starting some fluids. You might even be contemplating atropine until you see that EKG. Heck, you might still give some atropine to this patient to make everyone else feel better, that you're not crazy for not giving them
Good, we're following
atropine.
the algorithm.
But remember, you're managing the airway, right? IV vasoactive agents and pacing. So airway management here, this patient, again, they could talk to you. They could say things like roll tide, right? By the way, a shout out to all the other SEC fans that are rejoicing and going to laugh at how Alabama is going to have some lean years in the coming years. And by lean years, they won't be winning a title, every other year, right?
Yeah.
But anyways, I digress. By airway management, we're not just intubating this patient. This patient can say roll tide, right? So, if you just try to take this patient's airway right away, you're probably going to end up killing them. If they're breathing on their own with unstable bradycardia, just manage the bradycardia first, because managing that alone, you're going to get that patient to just wake up for you all of a sudden. And that's what you'll see when you start pacing these patients. They'll just be awake. They're like, what are you doing to me? If anything, they're going to get mad at you for pacing them because of how uncomfortable it can be.
Right.
And intubation, again, is probably going to kill your patient. Let's get into some of the meds. So sure, you can give
time for my soapbox.
Yeah, I know you can give a little bit of atropine, right? You can give some people say 0.5, some people say 1 milligram. You can do this up to 3 times. And I know you're just itching to get off. So I'm gonna put the box up, jump on that box, and just go off. Go, Briggs, go.
Let's be honest. This doesn't do anything. Just leave it at that. It's usually effective for like proximal AV block or sinus bradycardia with injunctional rhythms. It's not useful and probably harmful for any distal AV blocks or this wide QRS blocks. Overall, 28% of patients with bradycardia respond to atropine. That's all bradycardia. That's pretty bad. Yep. Whatever you do, don't give 0.5 atropine. Give the full dose. If you're going to do it, just do it. I've had a patient actually recently, like last week, come in and EMS said, we gave 0.5 3 times. I'm like, well, that was a waste of everyone's time. And it's been found that less than 1 milligram can actually cause paradoxical bradycardia. Yeah. Some interesting pathophys for that. We don't have to get into it. The whole point is don't do it.
But pro tip right there, right?
Pro tip right there. If you're going to do it, just do one and call it that. And if you know it's not going to work, you can go ahead and give it to make everybody happy in the room that we're following the whole ACLS algorithm. And then you can just jump ahead and then do
And
actual
you're not
things
some crazy
that work.
person who doesn't, like they're going to, we didn't even give atropine. What?
What is this doctor doing? They must listen to EM board bombs. Anyway, the next step that's actually going to do something here is that epinephrine drip and push dose epi here too. So epinephrine drip is the right call. It's superior to dopamine for so many reasons. I know dopamine is a triggering word for you.
What? Wait, hold on. Hold on a second. This is a cardiac thing that's going on. And you're telling me that I should not be pushing dopamine to this patient?
Yeah. But it's renal protective.
I am, I'm going to take my headphone off and just walk away here.
Yeah.
All right. Anyways.
We've
I feel like we're shattering like a lot of the things that med students and even I would say seasoned vets have like done for a while. So we need to be cautious and not like just blow their worlds completely here.
Yeah, and 90% of cardiologists. I didn't say that. Anyway, stick with epinephrine. This is your first line med.
Yeah.
We've kind of pooped on dopamine before in this podcast. We had an episode about inotropes in acute cardiogenic shock, and we talked about how important it was to give IV epinephrine over IV dopamine. Check that episode out for details. Yeah. But this is the same thing here. IV epinephrine is preferred, your first line vasopressor dash inotrope, whatever, for unstable bradycardia. Now, push dose pressors can be your friend here as the drip is being set up. The drip is 2 to 10 micrograms per minute infusion. You can also, of course, use a peripheral line for this. Don't be wasting your time with the central line here. This is a critical situation. The next option is something you mentioned earlier, which is what? This is cool.
Right, and this is calcium gluconate, 3 grams. So in patients where you don't have any labs and on this patient yet, you don't know if they're hyperkalemic or not. There are many bradycardias that respond to, calcium gluconate, and again, hyperkalemia, hypocalcemia, hypermagnesemia, and of course, calcium channel overdose. If you've already checked labs and ruled out these possibilities, then that's fine. But I would argue that in a patient like this that's presenting 3 grams of calcium gluconate is not going to, to kill them. No, if anything, it could potentially, be a game changer and save their life.
Right. Let's get into some electricity here. So this is something we don't do that often in pacing. And so we might feel a bit insecure doing it, but practice makes perfect. So we got to review it. There are 2 types of pacing. You got transcutaneous, transvenous, and transcutaneous is temporizing, right?
Yep.
It's a temporizing measure for definite care in a crashing bradycardia patient. And this is the case when you have more than a few minutes to correct the bradycardia. You want to do transvenous, but that's a whole different conversation, and it's intricate in terms of setting it up and everything like that.
Yeah.
Now, the only advantage... What do you say?
That you're like, it's intricate, and I was just thinking about all the steps in my head. I'm
all
like,
yeah. Essentially, it's a central line with a few extra wires.
Yeah.
Anyway, the only advantage to transcutaneous pacing is that it's not invasive, and it takes literally seconds to put someone on the pads and to start it. Now, what are the pitfalls? Well, there's a lot of pitfalls, but it's kind of what you're stuck with. Unfortunately, only about 30% of patients on average will get capture. Yeah. Now, good luck trying this on obese patients. It's going to be even probably lower than that. Yeah. And it also hurts. It's painful. You can try giving small doses of fentanyl because that's more hemodynamically neutral if you're trying to prevent some pain when the patient's crying out. But if you're needing large doses of electricity, it still hurts. And it's not a long-term solution by any means.
Yeah.
Your hope is that you're doing this as a temporizing measure until you can address the underlying cause potentially, or putting in a transvenous pacer, depending on the situation. There are only 2 switches on your defibrillator that allow you to transcutaneously pace. The amplitude, which is literally the amount of electricity in milliamps, it's usually written in MA, and the rate.
Hey, before you go further, you need to make this into a short. This is really good because I think a lot of people have a lot of anxiety when it comes to just using the Zoll and doing transcutaneous pacing. So start it off, Briggs. Start that short.
I like it.
This is really important. So get into how are you going to use that Zoll? How are you going to do transcutaneous pacing?
Yeah.
Go.
So whatever type of defibrillator pack you have, Zoll or Philips or whatever, it doesn't matter. Yeah. There's 2 switches on that monitor. 2 switches that allow you to transcutaneously pace. Switch number 1 is the amplitude, and that's the amount of electricity, and it's written in MA, milliamps. And then the rate.
Yeah.
You want to set the rate at 60 and leave it. Don't touch it any further. In the crashing patient, you're going to crank up the amplitude to 100. And then you want to titrate down about 5 to 20 above the minimum energy required for capture. So again, crank it up to 100. If you don't get capture, got to keep cranking it up. Unfortunately, may require more. It's going to hurt. They're painful. And again, we talked about the little doses of fentanyl.
But you're saying start at 100.
Start at 100. Great place to start. Then crank it up or down depending on if you get capture or not. If you don't, crank it up. If you do get capture, try to drop it a little bit so it's not as painful for the patient up to the level that you have capture. Now, again, what you're going to do here is if you're still not getting capture and you're increasing the dose to like 150 or something like that, you should be adjusting the pads. You should be doing something different than what you've been doing already, to try to improve the vector through the heart. If you got anterior lateral pads, you should do anterior posterior pads or vice versa, trying to manipulate things, the seal of the pad on the patient, etc., to make sure that
that's really important because it might not just, I'm not getting capture. I'm not, everyone is messing with the actual defibrillator. You need to be messing with the actual pads. I love it. All right.
For sure.
What else?
And then patients with obesity and COPD, we talked about this. They require like 40 to 80 milliamps more than the average patient to get capture. Again, just because of that
makes sense.
Amount of space you have to get through, either air for COPD patients, so their lungs are, of course, extra tissue.
Hey, mention the last part here. Let's go.
Yeah, this is big there. Never be fooled by the monitor that you have capture. There's a difference between electrical capture and mechanical capture. Electrical capture could be happening on the monitor, but you feel the pulse and it's still not 60 where you set the monitor at. The only way to tell if you have mechanical capture is to feel for a pulse, and that matches what you set the rate at. You can use POCUS here, but I see that as an extra step as much as I like POCUS. Just feel for a pulse. Don't go for the carotid pulses, though, because the carotid pulses can sometimes have a reverberation or pulsation from the electricity you're doing in the chest. And so either go femoral or radial and see if that matches what you have the monitor set at. And that's really the tips and tricks here of transcutaneous pacing.
Done. I love it. That's going to make an awesome short. I think it's going to make a lot of people feel better about how do you transcutaneous pace a patient, especially when they have that wide complex rhythm and atropine's not going to do anything.
Cool. Hey, let's wrap this up, and I want you to get into the specific conditions and pearls about each of the causes of bradycardia. So we talked about a general unstable bradycardia approach. Some of these patients require something very specific about them to fix their bradycardia. So why don't we get into it? First is going to be a very obvious one, probably the most common cause of really unstable bradycardia.
Especially kind of an elderly, older person.
Right.
And this is really going to be an MI.
Yep.
So the priority here is getting them stable enough for cardiac catheterization. So inferior MIs, they tend to cause narrow complex, kind of transient vagal type bradycardia that is actually likely to respond to atropine versus anterior MIs, they tend to cause a more wide complex Brady dysrhythmias that require pacing. I think it's important here, the widowmaker. I think it's important here as well. If that patient's having chest pain or was having crushing chest pain and they come in with these types of rhythms, you need to get cardiology involved sooner than later. This is not one of those where you're just focusing on reperfusing and that's it. You're not really talking to the patient or early on, try to kind of elucidate from the patient what were some of the presenting symptoms when this happened. Was it like sudden onset chest pain? Were you having sudden onset and again, it can kind of overlap, right? Because bradycardia alone can cause the patient have diaphoresis and some of the things that go with ACS. And then you have hypothermia. How do you manage that, Dr. Briggs?
I wonder. I think you rewarm them.
Yeah, we have so many episodes. I feel like a couple of different episodes on this and some of the pitfalls that come with it. And then what else?
Mixed edema, give thyroid hormone, see our prior episodes, see our handout on this. Pretty straightforward.
Pro tip on giving thyroid, what's another thing? Agent, you need to give IV.
IV steroids.
There you go. And then again, we got a great episode on that. Lastly, beta blocker, calcium channel blocker, DHO overdose. Yeah, you're pacing. If it's not working, really be thinking about
the reason.
really
same with mixed edema too. If you're pacing mixed edema and you don't know it's mixed edema, there's a reason it's not working.
Yeah. There might be other stuff going on there.
Right.
And in those things you can try to keep the patient alive if they're crashing, but really concentrate on, again, these is for overdose, on giving this patient the reversal agents for these toxicities, whether it comes to insulin or lipid emulsion, for beta blocker, calcium channel blocker, and then digibine for digoxin. My gosh, if your patients are still on digoxin, right? Don't really know what to tell you here, but once in a while that still happens.
It's like theophylline.
I know, and I've not seen that one. I'll admit.
Yeah.
I still like had a dig patient the other week, and I was
Just
like,
roll your eyes.
I was just like, man, okay, fair enough.
Yeah. Let me guess, your cardiologist believes in atropine.
Hey, no comment. I'm
No
not going to say
comment.
anything.
Hey, that's
No
it. Let's wrap this up. We got places to be.
Yeah, we do.
You got to take more Tylenol and
I do.
ibuprofen.
Yeah, it's I think my next dose of antipyretics. We don't like to say Tylenol, ibuprofen, right?
Sorry about that. We're not sponsored.
Pro tip for our residents: we just like to say, "Did the patient have antipyretics?" Yes. No. Okay.
Yeah. Did they deaf us?
Yeah. And that's a
I love
shout out
saying
to
that. Yeah.
Dr. Mezenary out there, a guy that both of us love.
Man, second shout out for him recently on episodes.
That's true. We had another shout out to him as well. He's
like,
the
man.
He's the Jedi, he's total. I think
Jedi
he was both our Jedi masters.
He's definitely our Obi-Wan Kenobi.
Yes, there you go.
Yeah.
Obi-Wan. I wonder who would be Yoda then. It's probably be.
We don't want to
David
give that
Klein.
out. We don't want to give that out.
Mary. It's like a fusion between Mary Kay Ryan and
a whole group
Klein,
of people.
Right?
Yeah, we got to figure out Mace Windu later. All right, that's it. Check out EM Board Bombs, EM Rapid Bombs, our premium podcast at emboardbombs.com. We offer residency discounts as well. If you have a group of residents that you are trying to cram for the ITE, which is coming up in less than 6 weeks.
Yeah.
So check that out.
Yeah, if you want to band together and just get a couple residents together and you guys can get our group kind of residency discount plan, we're happy to set that up for you guys.
For sure.
Hey, Briggs, I appreciate you
Absolutely.
working around my illness. Thanks, man. Appreciate it.
It's my pleasure. My pleasure. Teamwork, baby. All right. Talk to you later.